So I'm Gaia Dharmagesan, the Project Officer at Cancer Council Australia, and I'm here to present a web-based resource for culturally and linguistically diverse communities affected by cancer. So Kathy's... sorry. Okay. So Kathy is here to talk about the research a bit more. I'm here to talk about the project a bit. So during the research that we were conducting, the voices we heard from the communities that about the cancer, when we asked the question, what is cancer? It's a horrible disease. Cancer is a scary thing. We don't say the word cancer. When we are discussing it with the family, we don't talk about it, or we are scared to talk about it. Those are the comments that we got it from the community. And also they mentioned there is not much information in language about cancer, why we are getting cancer, causes of cancer, and often they believed they get cancer because some sort of bad things they did in the past, and now they are getting punished for it, and or some sort of karma they got it. So sorry, I'm going backwards. Okay, so the aim of the project is to develop a suite of resources which begin to address barriers of literacy and health literacy in CALD populations, particularly in Arabic, Chinese, and Vietnamese communities. I got some statistics also about the latest statistics from about the populations and the health literacy issues. The project objectives were to scope the need for accessible translated cancer cancer information resources in specific CALD communities, to address health literacy issues, to understand the cultural information needs, to develop materials to address needs, to disseminate and evaluate new resources, and to improve accessibility of cancer-related resources. So the engagement strategies we established during our project was partnerships. So CALD Resources Advisory Committee was established from the members from State Cancer Council, community members, community leaders, community organizations, health professionals, cancer specialized organization, and interpreting services. And I also can say that the whole project was built by engagement process called co-design, where all critical stakeholders from experts to end users were encouraged to participate and were respected as equal partners, sharing experience in the design of the resources. And also we had a scientific process. The resources were informed by a literature review and assessment of existing cancer information resources targeted to these communities, followed by an engagement with members of identified communities. So Kathy is here to talk about the community engagement part. I'll hand over to you. Thank you.
So stage one of the project was doing a literature review which explored, in relation to the three communities, cancer knowledge, attitudes and belief, preferred modes of access and barriers to accessing cancer information. So what was revealed in this short literature review was that there was cultural differences in cancer beliefs, including fatalistic views that hindered health-seeking behaviour, mistrust of Western medical systems and health professionals and cancer treatments, limited understanding of cancer across the continuum, and preferred modes of access to health information in order of priority: family members, multicultural health work professionals, community networks and the internet. There was also an environmental scan of all the resources available that had been translated, and that this was revealed limited accessible online audio and written resources that were often just direct translations from English. So when I joined the Cancer Council Australia, I came in and we recruited 6 bilingual, well, there was actually 8 bilingual workers. So we did 6 focus groups. There was a limited budget, so we did training with bilingual workers, and then they went out and recruited people who had cancer and their carers, and also recruited people affected by cancer. So they had to, that was the definition. So people who had an interest in it. So it was about half-half, direct contact and affected. The focus groups were in Cantonese and Mandarin together. There were 2 Vietnamese focus groups, and we actually held the Arabic-speaking focus groups with a group of men and then a group of women. And there was also 13 consultations with service providers. And that came about because of, 6 focus groups with 3 very diverse communities. It's just not getting enough information. So we also went to, Gaia and I talked to the service providers working with those communities, so key people involved. And if anyone wants a copy of our report or anything to know, the people that were consulted, we can provide that. So overall, the findings with the 3, and I've just grouped it all together, but of course we did separate it out. But for today, a lack of access and knowledge of translated information with cancer-related websites. So what was actually happening was when the communities tried to search for information, they actually found other information more easily than those, Cancer Council. They talked about Cancer Council in general because, confusion about which organisation is which. So Can Revive, different organisations like herbal treatments for treating cancer as well with the Vietnamese community. So easier access to information in language from overseas and ethnic organisations. Gaps in understanding about more prevalent types of cancer and the types of prevention, so especially with the Vietnamese community around hepatitis and how that leads to cancer in relation to liver cancer, or confusion about things like that, and sharing, contracting the disease and things like that. And then, breast and bowel cancer was talked about by the Chinese community more than other types of cancer. Cultural beliefs and language barriers and low health literacy was another finding, that it may prevent diagnosis and help seeking. So similar to the literature review. Patients with cancer, what they actually, it was interesting, a lot of the literature says distrust with health professionals, but in the focus groups and the stakeholder interviews, they talked about having the trust of their GP with all their life, or, they talked about trust a lot. The word trust was used a lot. But then they talked about actually being dissatisfied with the referrals, or waiting, that period of waiting for diagnosis, and the use of interpreters counselling. So it was the follow-up and being disappointed. So it's interesting that instead of just mistrust, it's actually trust, but what's happening, because they never thought they would experience something like this, and they went to their doctor first for trust. Cancer organisations have reduced the amount of consultation, so there used to be a lot of consultation with community groups saying we've launched these resources, and now there's no longer that contact that they were talking about. The doctors could provide more information about screening, and lack of interpreters and bilingual counselling, confusion where to get the counselling from, is it free? Especially there are a lack of bilingual counselling free services now. I think So recommendations, very similar to the findings, but ensure resources meet the needs of communities. Cancer Council promote messages of healthy lifestyle, early diagnosis and timely treatment, and about survival to break that link between cancer equals death or fatalistic forms, the understandings of cancer. Translated resources being easily assessed, so looking at the search engine optimisation. So if you search in China, like people, they talked about not being able to access that information, and we know it's there on the websites. Best practice, not just translating it, getting it checked by community workers. Distribution strategy that connects with communities, so with change, with organisations that continues. And websites linked to culturally diverse communities, so a lot of support. And research report be disseminated, and this counselling was really not available when they looked for it as well. So I think time, but...
Yeah. You have time? Or? Yeah, okay.
Yeah,
so,
I've got one slide.
Yeah, so the outcome is producing the resources. The fact sheet is coming out in 3 languages, and we are producing 3 videos to complement those resources. The health professional is talking, and the survivor is, talking about her experience. So the fact sheet is going to have information related to what is cancer, causes of cancer, importance of prevention information, and shame and stigma, get to know its early signs and chance of surviving. So these resources are purely produced by, working with the communities. Sustainability, ongoing commitment to maintaining and updating the resources as they will become part of the National Cancer Information Resources managed by the Cancer Council National Publication Working Group. CALD Advisory Committee representatives will also provide support after the project period to the National Publication Working Group. Most of them are sitting on this both groups, and we also developing a marketing strategy beyond the project time. And way forward, we are writing up a journal article, and we are also looking for further grants to develop the project a bit further to address coordinated care or cancer care treatment. Okay, thank you.
Great. I had a number of questions there, and I think you answered them all as you went through, but I note the importance of trust and transparency and the feedback loops there, and I know you have quite a systemic way of going about that. I think that's really important to give the information back to the people who've helped you develop this work as well. So I guess more of a comment than a question. But who else had a question? We have time for probably one.
Hi, Suzanne Foster from the Cancer Institute. Just picking up that point of trust, we talk a lot about transfer of care of patients when they're coming from hospital and back into the community, and the same with transferring what is happening with the person. But I'm wondering, have we touched into that point of transfer of trust, and how do we transfer that trust to the next health professional? And I think that might be a key point that we haven't picked up on.
Yeah, I think that's definitely an issue about that coordinated care, the specialist, because they did talk about, like, there's so much trust with the community, especially the Arabic speaking, but just being disappointed. And also I didn't talk about health literacy, so developing that concept of, the definition is the individual's ability to access information. It's actually, they talked about families taking that, coming, when the GP is giving bad news, to come and get that information and maybe tell that information to the person later on when they're in a better state of mind. And maybe even, not saying the word cancer or Yeah, so I think there is a lot of potential, and even, it's a good question, yeah.
Hi, thank you for your presentation. I was just wondering whether, following on from the findings that you've had with the research, whether there's room for development of materials for health service providers in working with various different communities. Like you said, something that you might found in the Arabic community might not be relevant for the Chinese or the Vietnamese community, and so some sort of information to provide and how to deal and how to provide information to different communities. So just picking up from your research.
Do you want to talk about resources?
Yeah. So definitely. So you're asking to educate the health professional. Is that? Yeah. I think we got experience in the past in other projects that developing resources, informing cultural aspect of different communities and how to negotiate with the patient or the client in difficult situations. So something that we could develop for the health professional. I'm sure that it's different to 3 different communities. They are culturally, linguistically, different communities, but it's you can't actually produce something that could work for everyone. It's unique. Yeah. So the resources are sort of looking at it. So that's what we are working with the communities that separately to address that. So the videos are coming in a way that sort of address their issues, the particular community issues.
We might leave it there in the interest of time, but if we've got time at the end, we'll come back for more questions. And I do encourage people to catch up with the speakers during the break if you've got more questions and conversation if we don't get time to them today. But thank you both.
Thank you.